First of all, I want to thank the organization for inviting patient advocates for their presentations and our input. So like I said, my name is, been introduced, my name is Brechtje Verhoeven. First of all, if you're not familiar with us, what is patient advocacy? As patients, we have a unique experience to share. We've been ill, or our partners have been ill, so we know what care means, what quality of life means. And there's an official reason what's meaning about patient advocacy. You can read it all here, but I think the other one is maybe more important to me, because at its core the purpose of any patient involvement should be to improve the health of the experience of services for patients, their relatives, the carers and users of health and social care services, as well as the wider public. So what are we going to talk about? Of course, what are the challenges? What are our patient concerns? What do we have to deal with? What are the expectations? What are real possibilities? And also, how can we manage the hype? Because patients feel, and it's true, CAR-T is a significant advancement in the treatment of cancer. And it does offer new hope to patients who have no other treatment options left. So we read in the newspaper and all the other magazines that there is this new curative therapy. And you don't need to have a stem cell transplantation. And it is personalized medication. So it's really for you, right there, in front of you. However, there's no proof that it is a curative. So we need to really manage the hype. So if you're talking about clinical trials, what are the gaps in the evidence that it is a curative therapy? Of course, clinical trials were limited to single arm, now they're also randomized, open label, and also with a very short follow-up. There are challenges for assessment of treatment durability and also long-term safety, as well as the studies are in the early stages and they have not yet reported results to build evidence. But then what is promised? What do patients read, what they hear? Well, I want to survive. And I actually don't want to have this hematological stem cell transplantation because I've heard it sucks. So can't I have this CAR-T cell, doctor, what I've heard about? Well, it's said to be the fourth pillar to surgery, radiotherapy and chemotherapy, but I think it's very clear that you have to make, you have to make clear to patients that it can be a bridge to a stem cell transplantation, or that it's added after a stem cell transplantation. And still, sometimes a stem cell transplantation is just the safest options. Especially when you, and also from a financial point of view, if 120,000 euros is for a stem cell transplant, and we've heard up to 400,000 for a CAR-T cell, well, we just heard about reimbursement, that might be something for an institution to say, well, we give you the stem cell transplant. But still then, CAR-T is not suitable for every patient. So if patients read there is CAR-T and it will save your life and you can walk out the hospital and you can be cured and everything. I think it's very clear that's not the point. So you have to make sure that you can say, listen, maybe your T cells are not of good enough quality or you don't have enough of them. And then again, when you look at clinical trials, the inclusion and exclusion criteria, they select for a healthier patient with less comorbidities. And not only that, but we also like you to, your heart is in order, your kidneys, your other organs. You must feel a little bit fine, no autoimmune disease. But you are in your third or fourth line of treatment and you're about to die. Do you know the right patient? And I know I've heard yesterday the predictors for choosing the right patient for a successful CAR-T cell transplantation is still unknown. And I know you're looking for it, but it's still unknown. So what is the elephant in the room? If you talk about long-term success, effects on patients, there's still a lot of unknown issues. However, I don't want to be too negative. We also know that it does provide another treatment choice. So what are the challenges that we are facing? A lot of them have been covered already, but what do patients hear and think about it? First of all, they need to know that production takes 40 to 21 days, and in the meantime they can die. It's not an easy job. It's very expensive. We've just heard about the reimbursement. And not only that, because the geographical access, not every country is able to provide this treatment, or every city is able to provide this treatment. So it requests of people to travel, and they want to have this, they want to cure, so they go abroad, but it costs a lot of money, so at this time it is definitely not available to every patient. Reimbursement, we're unsure. We just heard about it's going to cost a lot of money, so it's not eligible for every patient. Cluster treatment centers. Well, I really like the idea that they have, not the idea, but the fact, for an instance, in England, in the UK, we just heard there are 9 centers and they're spread it around across the country. I also know that there were patient advocates who really advocated for that. Politics. Yeah, we have to travel a long time for treatment. So if you're negotiating in your country to have a treatment center, please, in the back of your mind, make sure that the centers are across the country and not clustered in 1 or 2 cities in the main areas. And I already talked about an exclusion of the trial access. So, other organizational challenges. The whole infrastructure and the production of CAR T-cell is not easy. We already heard that many people are involved in this, from the production to the infusion to aftercare, and that needs coordination among the various people and institutions. It also needs a lot of training, like we've heard 300 people, I think that is a lot, exactly, for every product again and again. But training is essential. Expertise, and because it's so complex, the need for communication is very, very important. And all that, if it doesn't go well, it will affect people's lives. It will affect people's lives. And for example, the slots to produce the CAR T cell, it happens that in the meantime, when the slot is full, people have to wait for a couple of weeks, they will die. And they do need to know this. And you should have a backup. I'm sure you will take care of that. So nurses and carers must be involved. Carers as well, because they have the first responsibility when they're back home to really key monitor the side effects. And they have to learn to recognize the symptoms. So this is the next slide. Oh, go back. Another thing about safety, that is of course all the adverse effects of CAR T-cell. They can be very challenging. And we've already heard a lot about them as well. Specifically the CRS with various grades. However, there's no consensus on how to measure the toxicity. So patients or patient advocates or patient organizations, they cannot compare, because grade 3 in one product is not the grade 3 in another product. And it's not suitable for every disease either. What carers also should know, it's not just the CRS, but it's also really how they can recognize all the other symptoms that are possibly life-threatening. High fever, low blood pressure, high heart rates, organ failures. And of course, the last one, there's a lot of unknown, but most likely depending on tumor load, how that happens. You can all say, so what? Then what? What I already said, it's going to be very important to really inform patients. We need not to follow the hype, but we want real and transparent information. What about you?
I didn't like to interrupt you, but I
Thank
must
you.
do it.
Oh,
Because at this
Really?
point, when we talk about what patients need and the information we need to bring to patients and to the society in general, I would like to jump first in the information that we should be getting from patients first. I mean, have we asked to them what they really want to know about the therapy? Because it's not only the good chance to have, to survive the disease, the curative promise, but it's also the unanswered questions that a lot of patients have about, for example, when they are going to experience the peak symptom burden, or how the trajectory of symptoms would look like in the treatment. And we working on the patient side, and patient organizations, we know that it's not common or it's not easy for patients to bring these questions to their doctors when they have all the anxiety and all the emotional burden behind. So I think that in order to inform properly, we should be also collecting the information from them, how they feel, how it feels to live or with those symptoms. I mean, we describe very well the symptoms from the clinical perspective. We measure everything, but the non-observable symptoms need to be described as well with the same efficiency, because it's not only about having efficacy in the treatment, cost-effective treatment, but must be acceptable, even desirable for patients. So I was listening to you that toxicity gradient scale, for example, differ across studies, so how we can compare that. If we could collect how patients feel, probably we could be feeding that information, and the perception of the symptoms and the value proposition at the end could be enhanced. And it will help to determine the broad efficacy of the treatment, and it is, for sure it will help to have a better interpretation of the clinical outcomes, but from a wide perspective. The treatment decision making probably could be enhanced as well. And we think that it will help to build also the communication, the relationship between the healthcare providers, the physicians, the nurses, and the patient. For example, in the context of Lymphoma Coalition, we have recently published a study that was presented in ASH last December about the outcomes, how the outcomes are improved where patients are better informed. And this could be applied, and also, I'm sure, in the context of CAR-T. So everything at the end is about bringing a better concept of value, and also to feed regulators and even the payers in how these treatments should come to the market. And I don't want to talk about market access. We like to talk about patient access, because it's completely different. And this means that we need to collect patient-reported outcomes, but we need to also talk about the barriers we have in there. We know that we have more than 800, it's not a small number, more than 800 listed in the ProColit database. There is no consensus either on which would be the best instrument in hematologic settings and in blood cancers in general, not to mention in CAR-T. There has been some attempts to study and to try to put priorities in the instruments that are already available, depending on the disease and also the population, because it's not the same when we talk about children that when we talk about adults, and also depending on the age, the priorities may be slightly different. So we need to establish a consensus. We need to go into a deep study and analysis about these instruments.
Trials who have process and endpoints?
Yes, there has been certain people have been reluctant, industry and even some healthcare providers about incorporating the patient-reported outcomes in clinical trials before. And I fully understand and agree that there are concerns about the burden of this data collection for patients, is we consider that many of them are very ill and they don't feel like, answering questionnaires and a lot of questions and things. But it's mandatory to do the efforts. I mean, that's the simple and the easy answer, to say this is difficult to do, this adds burden to the patient, so no, let's jump into another thing. That's the easy way. But we like the challenge.
We do like a challenge.
And besides, we need that information as a supplement of what we already can measure in the clinical settings. So that is acceptable to talk about that, but we think that if we are not capable to bring solutions, so we are part of the problem, let's say. So how to collect in pediatric settings? We should be validating the data that comes from parents, from carers, from nurses. We have a lot of work to do in that area. But it's needed, definitely, and probably we shouldn't be starting from scratch, not to feel that frustration, but to take the learnings of the transplant. We did so many mistakes at the beginning. We were not collecting the data properly, or probably not in the comprehensive way that is collected nowadays. There are some instruments that have been already validated for the transplant, for allogenic transplant. So why not to start in that point? And from that bottom line, we could be like building something much better. And also to ensure that these parameters are collected uniformly, we need to harmonize from the beginning. For those who have been working in big data projects, for example, has been a real nightmare to harmonize the data. So we are in a spectacular moment, in a unique moment, to really establish a consensus and how to measure the toxicity, how to measure the patient-reported outcomes, the patient experience. We talk about patient centricity, but we are not really doing a good job yet. But we need to do it. We are on the good path. And we need to incorporate the patient voice from scratch, from the early stage of this development. That's a must. And it will be part also of the engagement with the regulatory settings and also with policymakers and payers at the very end. And we know that there are some clinical trials that are currently trying to incorporate patient-reported outcomes as an endpoint. That's a good thing. However, not all of them are including the same, not are using the same instrument. So again, if we cannot compare the grading scale for toxicity or for cytokine release syndromes, we won't compare neither these things.
I agree.
So what should come next? How we could address all this?
Well, I think, let's see about it. I think the most important thing is the long-term follow-up. And I would say 15 years. I mean, your child is 4 years old and receives CAR T.
Really? 15 years for pediatrics? I mean, I think that we were not speaking about 15 years if we die, let's say. So if we are discussing how long the follow-up should be, is because we recognize the promising, the perspective of extend life expectancy. So great, well done. But from now, we should be thinking how to offer a follow-up. We have been discussing about survivorship plans in cancer settings in general. And we know all the issues we already face. So why not to do it better now for the CAR T?
We have to do it better. We have learned from stem cell transplantation. Even then it took us 20 years, 30 years now before we start having this
And that's why we need to incorporate the patient representatives in senior decisions group to bring all these concerns and to bring all these questions. And it's important to prepare ourselves to provide the answers, because at the very end, the payers will bring those answers. And if we haven't done the homework well, we won't be able to provide the answers, the correct answers to the correct questions. And patient information, as you were telling before, is essential. I mean, it is crucial for this.
Well, if you look at, for example, all the products and you look at the patient information and the consent forms, they're about 27 pages long. How do you expect an ill patient read through all those patients and say, yes, I agree? I think one of the main point is that you really have to make all the information in lay language.
I'm happy you mentioned that, because probably it's not politically correct, but I will mention that in many cases we have discussed that some informed consents look like protecting the investigators rather than protecting the right of being correctly informed.
I agree, sometimes it does.
And also, when we talk about informing patients, we should incorporate also carers, because at the very end, they will be the ones who will support the patient, who will need to take decisions for late effects. For example, we know that some patients are developing the peak burden of symptoms in the first 2 weeks, but there is already data about patients developing the cytokine release syndrome on the 4th week. So what if you are already released from the hospital? If you don't have close to you one of these qualified centers. So your care need to recognize those symptoms and also to know what to do next.
And that means a lot of communication between institutions, between practitioners, between nurses, how to take over, and patients should know where to go to. And don't forget the single patients. They often don't have carers. What about them?
And here is where I think that patient organizations have a key role to try to connect all the people around, you know, and to provide correct and complete information, comprehensive, delivering packages of resources where you have already all the information. But we need to work in cooperation with the clinicians, with the healthcare systems, with policymakers, because these packages of resources should be available in the place where you are receiving the treatment. So it's not only about developing ourselves and putting our efforts there to do our best to inform well, but it's also about the willingness to provide that information timely.
Yeah, and not only that, I mean, I think working together with patient organizations from a clinician point of view is very helpful in that. So inform them as well and help them building up information and trust.
Yesterday was presented here, and part of the presentation mentioned the work, a workshop that IMA did last year. And one of the things that they mentioned at the end of that report, which is publicly available on their website, by the way, is the need to engage proactively patient organizations with registries. And we are on the perfect stage to talk about that, because we have EHA people here, we have EBMT people here. So patient organizations should be working in collaboration with registries in order to raise the awareness about the potential and how important, how relevant it is to bring all the data into the registries. And of course I want to think that patient-reported outcomes will be also there. And we need to raise awareness in that area and to understand that as much data we could collect, better prepared will be to do a good evaluation, to assess benefit and risk in a comprehensive way. So, as conclusions, as take-home messages, do you want to recap what you mentioned before?
Yes, well, first of all, patients need to be involved. I think that's clear already. Before CAR-T, there are some issues, like access schemes, good patient selections, selection, what I already talked about. The need for managing expectations, the media hype, how to deal with that, the expectations of patients, and of course close monitoring. Please.
And the multidisciplinary teams, the data collection, registries, continuous education, and I don't want to miss the chance to mention also the emotional burden, the psychological challenge for the patients, for the family to face these therapies. When you receive the new, apparently fantastic that you could go to this therapy, but at the same time the therapy brings a lot of risk, and how to live that moment, you know, between the leukapheresis and what comes next. So, I mean, in those days, you must be like, the anxiety can kill you, because it's difficult to manage that. I mean, we were just waiting to present here, and we were in panic. So could you imagine that is your life really in risk? So I don't want to be in that position, really. And long-term monitoring is essential, really. We need to work on that, on patient follow-up, and how to improve that follow-up, but not because of the follow-up, but to incorporate supportive strategies, and that's why it's so important to collect that information, how it feels from the patient perspective, in order to fit these supportive strategies, these schemes, in order to put all the resources in the hands of patients. And we know that resources are also challenging, because we will need the support to build these databases, to have the human resources capable to analyze and also to offer the interpretation of that data. That will be mandatory in the near future.
The more data you can get from patients, the better the information will be, and the better the treatments can be.
So we are about to move to the third generation, no? Aren't we?
We are.
I think we are in a perfect moment, not only to do all this homework, but also to involve patients from this early stage. So thank you very much.
Thank you.
So thank you both for your brilliant presentation and giving your demands. So I can start with the first question, because you attended this meeting all the time and you heard the presentation in this session. So what is really the patient perspective, for instance, in selecting the centers? You heard nicely from Tony in the UK. Were you involved in this as a patient organization in the center selection? Are you happy with this kind of how the centers are selected? And what is your position actually? Because we heard also at this meeting that the access to CAR T cells is not the same across Europe. So some centers have less or even no access. So what is your position there, or your?
Well, I can say about when you think about the centers, and I think they should be spread across the country. And I know, for example, that in the UK, the original idea was to have them all in London, well, most of them, and there were the patients that said, we really want them to have them across the country. And I think that's why you need patients in major senior decision groups, to make that choice against all odds, because it's money, it's politics, and sometimes it's not easy to be heard in that. And I think we really need a strong voice in senior decision groups to make that important decisions. Like, you know, now it's 70 miles, 70 kilometers to each center for a patient. Well, that's doable.
My experience in Spain is that there is, the government, the Ministry of Health is working hard in establishing and developing a plan for the access to advanced therapies, to innovative therapies, and there is a specific group working on the CAR T. They have involved 3 seats, 3 positions for patient representatives, and for the first time we are on the group that will make the decision, the final decision. I can even tell you that the Spanish Society for Hematology are in the experts group, but they are not in the final group that will make the decision. So this, we still don't know what is going to happen, but I must acknowledge that they are trying to incorporate from the beginning the voice. Access, equal access depending on the region. That's an area of concern on the world. On behalf of Lymphoma Coalition, I can tell you that we are really worried about this, because when we are in these settings, it's easy to hear about UK, Germany, Spain, Italy, Netherlands, but you don't have here people speaking about Romania and Slovakia and Slovenia and Serbia. And I know that we have other countries that are not members, but are there, are part of Europe, not to mention other continents. So we work at global level, and we really worry about how to improve access.
Monique was first.
Thank you. I think you brought up a very important factor in the equation. That's the post-CAR treatment living style. And yesterday we heard about utility, and I was quite surprised that these data are still missing about the quality of life after CAR T-cell treatment. But to bring some positive effect to that, I must say that in the lymphoma patients, 5 out of 7 of my patients are completely back to work, 100%, paying their taxes, doing everything they need to do, having a family life. And that's something I have not seen after stem cell transplantation, after chemotherapy. So their recovery can be very quick. And I think if we have those utility data on their health and their quality of life, I think it will be a positive one compared to other treatments.
I'm very happy to hear that, but that still doesn't answer what will happen in 15 years. And now this is the patient voice, and we're very happy that it is successful. And of course, there are big, great stories, and I'm happy to be alive, so I do understand. But of course, based on previous results, we are scared something. It does come up. What will the modified cells do in my body in 20 years? We just don't know. Maybe nothing, but the fear is there.
Tony, one last question.
Well, it's a comment really. I think it's very valuable to have patient and public voice involved. It actually moderates decision making. So on all the clinical reference groups, and John knows this, I know this, we have 2/3 representatives, either patient or public representatives on all the groups, and clinicians will modify what they say in a meeting when there are 3 patients or 3 carers in the room. And so the decision process involves that, and public consultation also means that the charities inputted into the decision making around the centres. I think it was the centres were not just going to be in London. The initial view was there were going to be 4 to 6 centres, and that was increased to 9. But I think the patient and public voice, one of the important things is when you start talking about the security of a treatment to a patient, they will preferentially choose expertise, and they're willing to travel. I mean, as we've heard, patients have been crowdfunding in Europe to go to the United States. So they are willing to travel if they can access the therapy and they think it's going to be done well. So it's about bringing patient and public voice into the equation so that we get the best decision making.
I'm happy you mentioned that, because I didn't mention before, but regarding the follow-up, that's why it's so important to think how we will integrate, in the near future, must be immediately, the different levels of the healthcare system. We totally support the idea of having expertise. Of course, we want to be treated in centers that treat a big number of patients, and here we have still low numbers. So we support that idea must be spread in order to facilitate access to everybody. We need to support low and middle income countries, but we need also to think how we will integrate the other levels, primary care, for the follow-up, because at the end they could be also providing certain supportive treatments, and with the industry, which they can support also in developing patient support programs at the very end. So I'm very happy that the organizers on behalf of the two, I want to acknowledge the organizers to incorporate this presentation in the program. Has been very, very inspiring for us and for the purpose of our work as well.
Okay,
Thank you.
so we thank you both.